Hi, my name is Scott Simpson. In this lecture, we'll be discussing some basic cardiovascular findings on chest X-ray with CT and MRI correlation. Adequate assessment of the major cardiovascular structures is critical for accurate chest X-ray interpretation. This should always include a careful scrutiny of the aorta, pulmonary arteries, and cardiac silhouette. Attention should be made to not only size, but also location, overall shape, and density. We'll be discussing some key signs that can be used to help identify abnormalities of these cardiovascular structures, as well as some important clinical clues that can help arrive at a more specific diagnosis and guide additional imaging if necessary. Let's first focus on the aorta. The ascending aorta should not normally extend beyond the lateral border of the right atrium. That is, its contour should be more medial or closer to the spine. The aortic knob should be sharply defined, smoothly round, and to the left of the trachea, which often has a subtle indentation from the aortic arch. The descending thoracic aorta is normally closely opposed to the spine, has a uniform and straight course. In older age, we can sometimes see the descending aorta bow off the spine, which could be a manifestation of decreasing height or systemic hypertension. Now let's contrast these normal findings to some diseased aortas by applying some of the rules we just learned. In this case, we can see that the ascending aorta extends beyond the outer edge of the right atrium. In addition, the aortic knob appears enlarged, less circular, and less smooth than typically seen. The descending thoracic aortic stripe is also quite lateral to the thoracic spine and has a very undulating course. These findings would suggest the presence of an aortic aneurysm. Clinical history and comparison x-rays are quite important in this scenario. Should the patient have no priors or be presenting with acute chest pain, particularly if radiating to the back, a CTA of the chest should be considered to assess for dissection. This patient had prior chest x-rays that showed this to be a stable finding and was currently asymptomatic. This patient has a known aortic aneurysm and has been undergoing annual surveillance imaging with MRI. Aneurysms can be surveilled with CT or MRI, and this patient was being followed with the latter. This is an axial non-contrast MRA black blood image of the aorta at the level of the aortic arch. As we move more inferiorly, we can see the ascending as well as the descending thoracic aortas. The ascending aorta is aneurysmal, measuring 5.7 centimeters, and has been slowly enlarging over the last few years. A more caudal image demonstrates the aortic root, the descending thoracic aorta, as well as some of the cardiac chambers. We also note that the aortic root, that is the very first part of the aorta just beyond the aortic valve and proximal to the sonatubular junction, is also aneurysmal. Given gradual growth, this patient was electively repaired. An aneurysm is defined as being greater than 150% of the normal vessel caliber. The question then becomes, what is a normal vessel caliber? And that is not a straightforward answer with regard to the aorta. Caliber varies by age, sex, body surface area, and the part of the aorta measured, that is ascending versus descending. As noted in a recent white paper, the ascending and descending thoracic aortas are said to be aneurysmal when measuring greater than 5 and 4 centimeters respectively. They are often repaired electively when measuring greater than 5.5 centimeters unless the patient has risk factors such as Marfan's or a bicuspid aortic valve, conditions that predispose these individuals to dissection. Let's look at a similar appearing case. We can again see that the ascending aorta extends beyond the right atrial border and that the descending aorta is going off the spine. The aortic knob looks well formed in this case. This looks less ominous than what we previously saw. However, this patient had a history of Marfan syndrome and is presenting with acute chest pain. This raises concern for dissection. A CTA was subsequently performed. Contrast-enhanced CT images at the level of the aortic arch demonstrates a line within the aortic arch representing an intimal flap. This appears to be extending into the brachiocephalic artery, noted as the more anterior ara. At the level of the mid-aorta, we can note the intimal flap within the ascending and descending thoracic aortas, again outlined by red arrows. In the descending aorta, we also notice a hole within the intima. This represents the exit tear, outlined here with this blue star. The dissection creates two columns of blood. The first being the true lumen, which is continuous with the left ventricular outflow tract, and the false lumen, where blood is dissecting between the layers in the media. Typically, the true lumen is smaller in size due to compression from tension of blood accumulating within the false lumen, and the true lumen also tends to be the more medially directed channel, as we can see in this case. We are now at the level of the aortic root, where we can see portions of the left ventricle and left atrium, as well as the aortic valve, which is outlined in purple. Note how there is again an intimal flap within the aortic root. In addition, within this aortic flap, we could see another hole representing the entry tear. At this level, it's also important to note if the dissection extends into the coronary arteries, which are not included in this study. Luckily for this patient, the dissection flap did not extend into the coronary arteries. We can again see how the flap divides the aorta into true and false lumens, and how the true lumen is continuous with the left ventricular outflow tract, is smaller in size, and is more medially oriented compared to the larger and more laterally located false lumen. This, of course, is an example of an aortic dissection, which is defined as having both an entry and an exit tear, which allows blood to accumulate within a false lumen. Morbidity and mortality can result from rupture, where we could see hemorrhage in the mediastinum or pericardium that can cause tamponade, or from ischemia, a consequence of the flap occluding another artery, such as the coronary arteries leading to a myocardial infarction, the carotid arteries leading to a stroke, or the superior mesenteric artery causing bowel ischemia. There are different ways of classifying aortic dissections. The most common and easiest to use is the Stanford system. A type A aortic dissection involves the ascending aorta with or without arch or descending aortic involvement, whereas a type B dissection does not involve the ascending aorta. Recently, a type B star dissection has been introduced. These are dissections that start in the descending aorta and then propagate into the aortic arch, but not the ascending aorta. Type A's are typically treated as surgical emergencies, whereas type B's and type B stars may be managed medically with blood pressure control, which is why it's important to make these distinctions. Here's another case of a very abnormal appearing aorta. The ascending aorta looks to be okay, as it does not appear to be protruding beyond the right atrial border. But what about the aortic arch? It looks very abnormal. It is poorly defined, has an irregular border, and appears enlarged. Also notice how wide the mediastinum is, much too wide even for a patient lying flat. Just as important, the mediastinum is not only wide, but just too dense and too white. This tells us that something may be accumulating there. And if this is the case, we want to look for mass effect. Observe how the trachea is being pushed to the right and deviated from midline by this abnormality. Also note how the left main stem bronchus is being pushed inferiorly, how it has a sagging appearance. Are there any additional ancillary findings that we notice on this chest X-ray? The left hemithorax appears vaguely dense, having a veil-like appearance. There is also opacity at the left lung apex, representing what's known as an apical cap. This represents a layering pleural effusion. You may be wondering, wait a minute, where is the blunting of the costophrenic angle? But how does one have to be positioned to develop blunting? They have to be upright. And how is this patient positioned? They are positioned supine. So when supine, the fluid tracks along the posterior tracts, evenly resulting in this vague density with fluid accumulating near the lung apex. I think at this point we should all be pretty worried that something has gone quite wrong with this patient, and indeed they were involved in a motor vehicle accident as an unrestrained driver. In this scenario, we are very worried about an acute traumatic aortic injury. An emergency TA was obtained. At the level of the aortic arch, we notice an opacified aorta. However, surrounding this opacified aorta is this abnormal soft tissue replacing the mediastinal fat. This represents hemorrhage, which has caused all the mass effect on the trachea and the left main stem bronchus we saw in the chest X-ray. Also note the left-sided pleural effusion. This represented the veil-like density that we saw as the patient was laying down. In this case, this represented a hemothorax. Just inferior at the level of the mid-aorta, we see surrounding hemorrhage, but also notice a flap within the ascending aorta. This represents an intimal injury, an intimal tear. A little bit further down, we again see the extent of the injury. We notice the ascending aorta, descending aorta, and again the flap within the descending thoracic aorta. This represents what we call an acute traumatic aortic injury, which represents a partial or complete tear of the aorta. These are life-threatening, with some patients not even living to reach the hospital, let alone getting a CTA. These are characterized by an abnormal contour of the aorta, typically at the level of the aortic knob, on chest x-ray with associated mediastinal widening, increased density of the mediastinum, resultant mass effect on the trachea, and possibly a hemothorax. What about this case? PA and lateral views of the chest. What is wrong with this aorta? The ascending aorta looks to be okay, but what about the aortic knob? We do not see it in its normal expected position. Also, which way is the trachea moving? In this case, we could see that it's subtly deviated to the left. And which way does it normally move with a left-sided aortic arch? We should see it normally to the right. So what could be going on here? This actually represents a right-sided aortic arch. The aortic knob is on the wrong side. Also note how we do not see the normal descending aortic stripe. It is now somewhat to the right of midline. What about on the lateral view? What's going on with the trachea here? We can see that it's displaced anteriorly. So not only is it going the wrong way to the left, it's also being pushed anteriorly. This is because the right-sided aortic arches are typically associated with an aberrant left subclavian artery. This has a course that's both posterior to the trachea and the esophagus. Because it's horizontally oriented, it's going to appear as a circle on the lateral view. In addition, for congenital reasons, these aberrant subclavian arteries can become dilated, which can then push on the trachea and esophagus, potentially producing symptoms. So how does this look on CT? Near the thoracic inlet, we can see a superiorly located right-sided aortic arch. Also note the aberrant left subclavian artery. Further down, we can confirm that the arch is truly right-sided. We can also see the abnormal course of the left subclavian artery, which is posterior to the trachea. Also observe how dilated it is at its origin. When dilated, this is known as a diverticulum of Kummerow. This dilation is what deviated the trachea anteriorly on that lateral view. And look at the poor esophagus, which is smushed between the trachea, which is being displaced anteriorly, and the dilated aberrant left subclavian artery. At the level of the heart, we notice how the aorta is seen to be descending on the right, which is why we do not see the normal left-sided descending aortic stripe on the frontal view. This is a case of a right-sided aortic arch with an aberrant subclavian artery, which is generally not associated with any major cardiac anomalies, unlike some other congenital aberrant configurations of the aorta. Remember that this aberrant artery can become dilated, known as a diverticulum of Kummerow, which can cause esophageal compression. If symptomatic, this is known as dysphagia lusoria. In addition, this results in a vascular ring around the trachea, completed by the ligamentum arteriosum, which typically arrives from the diverticulum. This can cause tracheal compression and stridorous symptoms. Let's now move on to the pulmonary artery and some key points regarding the structure. We should remember that the main pulmonary artery is the bump just below the aortic knob. In general, this contour should not extend beyond a tangential line drawn between the aortic knob and the apex of the left ventricle. Notice how the main pulmonary artery is tucked in, that is medial to this line. What cardiomediastinal contour is abnormal in this case? The ascending aorta looks to be okay. Where is the aortic knob? You may think that this is it, however this is not the case. If you follow the descending aortic stripe from below, you can see that the aortic knob is actually located just above this bump. This is the location of the normal aortic knob. So the question then becomes, what is this bump? This actually represents the main pulmonary artery, and it's way too big. Let's draw again that tangential line from the aortic knob to the left ventricular apex. Remember, the main PA is supposed to be deep to it, and in this case it's sticking out beyond it. This signifies pulmonary artery enlargement. In addition, the intralobar pulmonary artery, which we see here, is also too big. We see that transverse measurements taken transverse to the orientation of the intralobar pulmonary artery should be less than 16 to 18 millimeters. In this case, it's much larger than that. When the main pulmonary artery is this big, it generally indicates pulmonary hypertension. The the pulmonary artery dilation can occur with other processes such as pulmonary valve stenosis, even in the absence of elevated pulmonary arterial pressures. On the right is an extreme case of pulmonary artery enlargement where a novice reader may interpret the main pulmonary artery as being a mass. There are numerous different causes of pulmonary hypertension, with the World Health Organization breaking them down into 5 different groups, listed from group 1 through group 5 here on the left. This is a case of an atrial septal defect, also known as an ASD. Here's the corresponding cardiac MRI, which is an excellent test to look for cardiac shunt detection. This is a bright blood sequence, 4-chamber view of the heart. Note the right ventricle, right atrium, and left ventricle. Also notice the big hole in the heart, reflecting the atrial septal defect, which allows communication with the left atrium and right atrium. Cardiac MRI also allows us to watch the heart contract in real time, where we can see swirling of blood between the 2 atrial chambers through the large atrial septal defect that was previously noted with the blue star. Let's now move on to the heart. One of the more basic fundamentals of chest X-ray interpretation is assessing for cardiac enlargement. This is most typically done with the cardiothoracic ratio. This is obtained by measuring the right atrium to midline, the most lateral portion of the left ventricle to midline, and then summing them together. A normal heart should be roughly half of the sum of the total width of the chest. Here's an example of cardiac silhouette enlargement, with one green line marking the outer edge of the right atrium and the other green line marking the outer edge of the left ventricle. Here's the distance from the right atrium to the midline. Here's the distance from the left ventricle to the midline. And then the 2 green lines here representing the total width of the chest, which is outlined in this orange arrow. We then sum the right atrium distance, the left ventricular distance, and we note how they're larger than half of the total width of the chest. This indicates cardiac enlargement. In general, people do not take these measurements. A simpler and more visual and easier way of doing this is to take the right atrial measurement and see if it fits in the clear space between the outer edge of the left ventricle and the left chest wall. Should it be bigger than this clear space, then by rules of geometry, the heart has to be greater than 50% of the total width of the chest. So this measurement comes with some rules. First, the patient has to be well positioned and not rotated. Second, they have to be upright. Third, it should be obtained as a PA view of the chest, that is posterior to anterior. And lastly, the chest X-ray needs to be acquired during full inspiration. Any of these rules, if not met, could result in pseudo-cardiac silhouette enlargement. Here's an example of a patient with chest X-rays obtained within hours of each other. One with low lung volumes and AP technique, the other with an adequate inspiration and PA technique. Look how much the heart changes in size. It's important that when you start reading chest X-rays not to overdiagnose cardiomegaly, particularly on inpatients and portable exams, which are almost never upright, PA, or in full inspiration. You should also note that not all things that enlarge the cardiac silhouette are related to cardiac chamber enlargement. A pericardial effusion can also cause cardiac silhouette enlargement. We would suspect a pericardial effusion should the heart change rapidly in size in the frontal view. The silhouette may appear globular, though I think this is not a very specific or sensitive sign. A more reliable marker is what's known as the Oreo cookie or epicardial fat pad sign, which we see on the lateral view. Here's the corresponding lateral view, and note how we see some loosened stripes anteriorly, so let's blow that area up. Notice how we see 2 loosened lines. This represents fat deep and superficial to the pericardium. The intervening density represents the pericardial effusion, which we see here. The appearance has been likened to that of an Oreo cookie. Corresponding CT demonstrates the pericardial effusion in white, and then the fat, both deep and superficial to it, in gray. Again, really notice those 2 loosened stripes, a characteristic appearance of pericardial effusion on chest X-ray. There are many causes of pericardial effusion ranging from autoimmune diseases, infections such as tuberculosis, malignancy, and hemorrhage. Inflammatory pericardial effusions can result in complications like seen on this lateral view. Notice the dense white line surrounding the heart representing pericardial calcifications from prior uremic pericarditis. Pericardial calcifications can result in impaired diastolic filling of the heart, known as a constrictive cardiomyopathy. Let's now talk about how to recognize if a particular chamber of the heart is enlarged. This can be quite difficult to do, particularly if the heart is globally enlarged, though there are some specific signs that can increase our accuracy. Let's first talk about the left atrium. Remember that the left atrium is largely not contour forming, with the exception of the left atrial appendage, which is generally not discretely seen as a prominent contour. Some specific signs we will use and address will be the double density sign, enlargement of the left atrial appendage, splaying of the carina, a horizontal orientation of the left mainstem bronchus, and displacement of the airways in the lateral view. Notice on the left how there's a relatively smooth border of the upper left heart border, which is just inferior to the left main pulmonary artery. Compare this to the study on the right, which demonstrates left atrial enlargement. Notice the prominent contour below the main pulmonary artery shadow from an enlarged left atrial appendage. Also notice on the right how there appears to be two cardiac contours on the right, one that's deep to the right atrial contour, which we see outlined with these red arrows and shaded in red here. This is what's known as a double density sign, and this signifies left atrial enlargement. If a double density sign is recognized, we can take a measurement from the apex of the left atrial contour to the center of the left mainstem bronchus. A measurement greater than 7 centimeters is fairly specific for left atrial enlargement, which we could see in this case. Also notice the shape of the carina. On a normal study, the carina appears relatively acute. The angle that it forms appears relatively acute, whereas in the setting of left atrial enlargement, it appears more obtuse. This is the result from infra-adjacent mass effect from an enlarged left atrium, which results in splaying of the carina, a more obtuse appearance of the carina. On the lateral view, the left atrium represents the most superior and posterior aspect of the cardiac contour, which is seen here. When enlarged, it projects more posteriorly and can even overlap the spine, as noted on the right. Also notice how there's mass effect in upward and posterior displacement of the airways secondary to left atrial enlargement. There's posterior airway displacement. Normally there's a minimal amount of mass effect on the esophagus, which can be observed in the setting of an esophagram. Notice how there's a subtle indentation of the mid-esophagus on this normal person on the left. When the left atrium is enlarged, the mass effect on the esophagus can become quite accentuated, which we can see here as significant extrinsic compression of the esophagus on the esophagram. Some additional findings that we had covered are also present in this case. There is main pulmonary artery enlargement. There's also cephalization. Also notice how the right atrial border on the right appears to be elongated and enlarged, signifying right heart enlargement. The combination of a normal-sized left ventricle with left atrial enlargement, findings of pulmonary hypertension, and right heart enlargement are suggestive of mitral stenosis, which this patient had. The most common cause is rheumatic heart disease, which has significantly decreased in incidence over the years. Stenosis impedes blood flow into the left ventricle, which then results in left atrial enlargement. Left atrial enlargement results in blood flow backing into the pulmonary veins, leading to pulmonary venous pressures being elevated and cephalization on the chest X-ray. Further backing up of blood into the pulmonary arteries results in elevated pulmonary artery pressures and a dilated main pulmonary artery, with further backing up blood into the right heart, resulting in elevated right heart pressures, eventually an enlarged right heart, and then if left long-standing, could lead to right heart dysfunction. So let's move on to the left ventricle, which we remember forms the majority of the left heart border on the frontal view and the inferior and posterior border on the lateral view. When enlarged, the apex is shifted inferiorly, and a specific measurement on the lateral view, known as the Hoffman-Rigler sign, can be observed, two signs that we'll be looking for. On the left is a normal patient, and on the right, one with left ventricular enlargement. Outlined in pink is the left ventricular border. Applying the 50% rule, the heart on the right appears slightly enlarged. More importantly, note the direction of the apex of the heart. On the left, the apex of the heart is somewhat horizontally directed, whereas on the right it is downsloping, that is pointing more inferiorly. This is a sign of left ventricular enlargement. The appearance of a downsloping and prominent left ventricular border has been likened to a shmoo, a fairly creepy appearing cartoon from the early 50s, one that's been haunting my nightmares since I learned of this sign. This is what's known as the shmoo sign. On the lateral view, the left ventricle is seen to be forming the posterior and inferior aspect of the heart, outlined in pink here. On the right, we can see an enlarged left ventricle, which is directed more posteriorly. Let's blow up this area to get a closer look. So again, here's the left ventricle, normal on the left and abnormal on the right. We also notice another line, which is outlined with these blue arrows. This represents what's known as the IVC reflection, and here's a blue line outlining that. What we could do to measure the distance of the left ventricle for more quantitative assessment to determine if there's left ventricular enlargement is come 2 centimeters perpendicular to the diaphragms at the level of the IVC reflection, and then measure perpendicular to that to the most posterior border of the left ventricle. As the left ventricle enlarges, this distance will become larger and larger. We can see on the normal person on the left, it measures 0.8 centimeters, and on the right, it measures 2.2 centimeters. There's considered to be left ventricular enlargement when this measurement measures greater than 1.8 centimeters. The bottom line here is that as the left ventricle enlarges, the posterior aspect of it becomes more and more posteriorly located, further away from the IVC reflection. This patient had a dilated cardiomyopathy, which predominantly affected their left ventricle. This basically means that the left ventricle is enlarged and generally not working well, resulting in a very low ejection fraction and poor forward flow. The two major categories for dilated cardiomyopathies are ischemic, from prior myocardial infarctions, and non-ischemic. On the right, we have short-axis bright blood images of the heart obtained as part of a contrast-enhanced cardiac MRI. We can watch the heart beat on Cine images. The right ventricle is the more anteriorly located chamber, and the left ventricle, the more posterior, rounded, and thicker walled chamber. Notice how in general the left ventricle appears somewhat sluggish in its contraction, corresponding to a low ejection fraction. In addition, some of the walls appear to be moving less well. That is, they're described as being hypokinetic, moving more sluggishly. These walls correspond to the distributions of the left anterior descending artery and the circumflex artery vascular territories. On post-contrast inversion recovery images, where we null or blacken the myocardium, we can see that there is increased signal in a subendocardial distribution representing enhancement. This signifies scar from a prior LAD infarct and accounts for the more regional wall motion abnormalities we saw on the Cine short axis clip. This person had a dilated cardiomyopathy from prior infarcts. Another consideration, should both the ascending aorta and left ventricle be dilated, is the presence of aortic regurgitation. Aortic regurgitation, we can see a dilated ascending aorta as well as a dilated left ventricle, as this person had here on the right. Right heart enlargement can be difficult to recognize, particularly should the left heart be enlarged. This is particularly true when we see left ventricular enlargement, which can cause crowding and movement of the cardiac structures. When only the right heart is enlarged, we can observe a prominent right atrial border, as we saw in the case of long-standing mitral stenosis, and obliteration of the retrocardiac clear space. The causes are multiple, with the most common being left heart dysfunction. On the left is a normal chest x-ray, and on the right someone with right heart enlargement. Notice the prominent and elongated right heart border when compared to the normal side. As the right heart border becomes enlarged, it progressively moves further and further lateral from midline. This represents right atrial enlargement. On the lateral view, the right ventricular outflow tract and right ventricle represent the most anterior cardiac border, which is seen here, outlined in blue arrows. Notice the more superior and horizontal location of the RV and RVOT when they become enlarged. This is them again outlined in blue. Notice how again the right ventricle and right ventricular outflow tract becomes more superiorly displaced and horizontal in shape when they become enlarged. As the right ventricle becomes progressively larger in size, the retrosternal clear space becomes progressively smaller in size. Notice how there is a difference in size between the retrosternal clear space on the right and the retrosternal clear space on the left, with on the right being smaller in size from an enlarged right ventricle. Additional abnormal contours are also present. The main pulmonary artery contour we can see is enlarged. We also note that there's distension of the azygous vein, which is seen here, indicating elevated right-sided pressures. Also notice at the right lung base, there's silhouetting of the diaphragm and a wedge-shaped opacity, representing a pulmonary infarct. This is a case of chronic thromboembolic related pulmonary hypertension, also known as CTEPH, that resulted in right heart dilation and dysfunction. CT images on the left, following contrast, demonstrate an enlarged pulmonary artery shaded in blue, eccentric filling defects shaded in green, representing chronic pulmonary emboli. This led to pulmonary hypertension and eventually from long-standing elevated pressures, right ventricular hypertrophy, and enlargement. Progressive enlargement of the right ventricle, in addition to elevated right-sided pressures, led to tricuspid valve dysfunction, regurgitation, and eventually right atrial enlargement. Lung windows demonstrate wedge-shaped peripheral areas of consolidation, representing infarcts seen in red. This is also known as a Hampton's hump, a chest X-ray sign in a setting of typically acute pulmonary emboli. In conclusion, assessing the major cardiovascular structures on chest X-rays is critical. In this lecture, we focus specifically on abnormalities of the aorta, pulmonary arteries, and cardiac silhouette, which demonstrated that it is not only important to assess size, but also shape and location. We also highlighted some ancillary findings, clinical clues, and signs that may lead to a specific diagnosis. Thank you for your time. If there are any questions, please feel free to email me. Thank you.